When I was asked to do this talk originally, I didn't know whether to be utterly delighted or slightly despairing because there isn't much evidence around what we do. So the advantages of that are I could probably say anything and nothing's really wrong. But the disadvantage is that there's what data we might have that might be extrapolated to these patient groups is vast and broad and all over the place. And we could probably talk till National Thrombosis Week next year, looking at all the various studies that might be relevant. So, what are the risk factors for cancer thrombosis? So, in any patient with thrombosis, usually the reason they get a thrombosis is multifactorial, and cancer patients are no different in this setting. So we've got patient-related factors, and these would be relevant to any patient with a thrombosis. Age, we're aware that increasing age is associated with increasing risk of thrombosis, increasing BMI, multiple medical comorbidities, a general poor performance status, and these are applicable to cancer patients and may well change during the cancer patient's journey, so they're not necessarily static. We've got cancer-related factors, so the tumour type and site, the stage of the tumour, the histology, the time since diagnosis, and as Professor Noble said, we're increasingly understanding more and more about malignancies, and we're diagnosing them at molecular levels, we're diagnosing relapses at molecular levels, and even within the same cancer, over a period of time, they may not really be the same disease, as it were, and their thrombogenicity and their potential to cause a thrombosis is likely to change over a period of time as we treat it. And then finally, there's the treatment-related factors, so chemotherapy, immunotherapy, hormonal treatments, radiation, surgery, patients being in hospital, indwelling vascular access, and again, those are going to change over time. So in cancer thrombosis patients, we've got really quite a complicated mix. It's hard enough in a patient without cancer, but with patients with cancer, it becomes really quite complicated and really quite multifaceted. And I think we're kind of clear at the moment until the trials come out looking at the direct oral anticoagulants up front in cancer. I think the consensus nationally and internationally is that one, on the whole, would use low molecular weight heparin up front, variety of low molecular weight heparins to choose from. And we're using it approximately for 6 months, different amounts, different settings, but generally for 6 months at treatment level. But beyond 6 months, it starts to become a bit more woolly, and we're slightly less clear about what we do. So our current recommendation, standard of treatment for cancer-associated thrombosis is 3 to 6 months with low molecular weight heparin, grade A evidence, lovely. But in patients with ongoing active cancer, consideration should be given to indefinite anticoagulation, but a decision should be made on a case-by-case basis, taking into consideration bleeding risk and patient preference. So we've got which patients, we've got which agents, we've got which dose, and what are the drawbacks. And I think the most difficult bits in that yellow statement really are the case-by-case basis, because it is quite individualised, and it's quite difficult to apply some of the things we're going to talk about to individual patients in the clinic. And patient preference, as Professor Noble alluded to in his talk earlier on in the morning session, starts to play a much bigger role beyond 6 months than perhaps it does upfront treating the cancer. So I thought, because it's the end of this session and because it's just before lunch, we'll have a little bit of audience participation in 2 cases, and then we can have a look at some of the evidence that's around or not around and see if it changes what we think towards the end of the talk. So patient AB is a patient who came through my clinic, a 65-year-old gentleman who had esophageal carcinoma diagnosed with local node involvement, and he had some preoperative chemotherapy with a cisplatin-containing regime. He was diagnosed with an incidental pulmonary embolism 1 month after starting chemotherapy, and was started on delta-pyrin 200 units per kilo, and after the first month, as per the standard recommendations, was brought down to 150 units per kilogram. Tolerated this beautifully, no complications, really took to injections very well. He had an esophagectomy, a successful resection, managed to bridge his anticoagulation, no problem, made a very good recovery, and then was due to have further ECX chemotherapy, so cisplatin-containing regime, post-operatively. And after 6 months of therapeutic dalteparin at 150 units per kilo, the patient is still receiving chemotherapy, and subsequent scans have shown, and I've put in inverted commas, complete resolution of the thrombus. There's no radiological evidence of persistent thrombosis. He's doing beautifully, and he wants to know whether he should carry on with his dalteparin. So he's had 6 months of treatment for his clot. He's got a bit more chemotherapy still to go before the oncologists are going to say, okay, you're clear, you're fine. How many of you in the audience would just keep going on his standard dose of low molecular weight heparin? Okay, so a few hands up, lovely, bit more audience participation. How many of you would leave him on low molecular weight heparin, but actually think about putting him down to a prophylactic dose, weight adjusted, 5,000, 7,500? Very good. And how many of you would start to discuss a direct oral anticoagulant or vitamin K antagonist? So, some in the setting. Very good. So we'll come on to what we did and how we got on later. So I think the vast majority would carry on from the numbers I've seen arms up. Vast majority would actually carry on at the same dose, followed by reduced down to prophylactic dalteparin, followed by direct oral anticoagulant or oral agent. So second patient, patient DE, a 45-year-old lady with breast carcinoma with nodal involvement who was treated with chemotherapy and surgery up front and had a proximal DVT during chemotherapy and post-operatively, not that close to surgery, and has completed 6 months of dalteparin, cancer successfully resected, and the oncologist would like to give this patient tamoxifen for 2 years as adjuvant treatment. So the oncologists write to you and say, does she need secondary prevention, and if so, which anticoagulant should I use? So how many of you would give some secondary prevention in this lady who's had a proximal DVT associated with her original treatment? Okay, so probably about a quarter to a third. And if you were going to give secondary prevention, would you use low molecular weight heparin? Hands up. Would you use a direct oral anticoagulant? And would you use a vitamin K antagonist? Okay, so for those that can't see the numbers, of those that would give, most would use a direct oral anticoagulant, and then that equal for vitamin K antagonists and low molecular weight heparin. So, what evidence is there to guide management beyond 6 months? And I think from what we've heard so far and what we're going to see, it's quite limited. So we've got some evidence around VTE recurrence in patients who've had a first thrombosis and not necessarily associated with cancer. And the risk factors for first VTE, we see that transient reversible risk factors about 3%, continuing risk factors about 10% recurrence, and idiopathic about 10% recurrence. And within the continuing risk factors, cancer is a bit lower. Now we have some prediction models for VTE recurrence. We've got the DASH score, we've got the Vienna prediction model, and we've got the HER2 score, trying to help us with patients with a first VTE look at what the risk is of a recurrent thrombosis and whether we should continue anticoagulation long term to keep the patients well and avoid the complications of long-term recurrent thrombosis long term. But they have limited value, and they've had limited validation studies done in patients without cancer, and in patients with cancer we've no idea whether they're relevant. So we can look at men, we can look at older age, and we can look at elevated D-dimer, but none of these have been validated in the cancer setting. So I think we can't really use those reliably to say should these patients continue anticoagulation beyond 6 months. We have the Corona score that we've heard about earlier, looking at risk of thrombosis in patients with cancer, the site of cancer, what the platelet count is before they start chemotherapy, what the hemoglobin is, white cell count, BMI. We can modify that and look at D-dimers and other biochemical markers within the blood. But this has only really been validated for initial VTE, and we can't really use it reliably after 6 months, because a lot of these factors won't be relevant if the patients have had treatment for their cancer alongside anticoagulation. So we're a bit stuck on predicting which patients, if they've had a clot before associated with cancer, are going to get a recurrent thrombosis. Do we have any data from the treatment trials? Can we extrapolate anything from these studies? And we can look at the plot study, which was randomisation of low molecular weight heparin against vitamin K antagonist warfarin in patients with cancer-associated thrombosis. The subgroup analysis showed that there were some independent risk factors of VTE recurrence, lung cancer and metastases, and there were some patient groups that were lower risk, such as breast cancer, but this is very difficult when you've got a patient sitting in front of you in clinic without any of these tumours, or even with some of these tumours, saying, well, it's quite difficult to try and give them an individualised or semi-individualised risk stratification score based on huge studies of historical data. And we do see, we've seen this slide and this data earlier on today, there is an increased cumulative incidence of first VTE recurrence, and patients with active cancer with predictors such as the CNS tumours, pancreatic tumours, metastatic disease do have a higher risk of recurrence. And those without predictors and active cancer more closely follow the other secondary VTE. So we could perhaps look and say, well, certain tumour groups at higher risk and certain patients with still widespread metastatic disease are at higher risk. And we can see from this data that continuing anticoagulation, certainly with a vitamin K antagonist, does reduce the risk of recurrence. So one could extrapolate that. If one continues to anticoagulate these patients, you may well reduce their risk of recurrent VTEs and potential complications. And the Ottawa score was developed by Luzardo et al, looking at various variables, female lung cancer, breast cancer. And again, you can get an idea of a risk, recurrent risk for a patient, but they're quite difficult to individualise in these settings. So we don't really have very good risk prediction scores for patients who've had a blood clot before, who've completed 6 months of anticoagulation, and those who might go on to develop complications. So is there anything else about the patient we can look at? One of the things that's been looked at in patients without cancer is residual vein thrombosis. So a patient's had a DVT, and in some patients probably embolism. If there's persistent thrombosis in the veins, if there's persistent abnormal flow, if there's persistent stenosis, does this seem to be associated with a recurrence? And in 242 patients with residual vein thrombosis, diagnosed by saying we can't compress the vein and of more than 40% diameter reduction, they were randomly assigned to receive a further 6 months of low molecular weight heparin, and there was 15% versus 22% recurrence in the 12-month follow-up. So not really statistically significant difference, p-value 0.175. So residual vein thrombosis doesn't seem to be a significant risk factor for ongoing thrombosis, and it's not a useful predictor for whether one should or shouldn't carry on anticoagulation. So that's not overly helpful either. Is there anything about the treatment the patient may be receiving? And now, the data on risk of thrombosis in patients on varying anti-neoplastic or immune modulatory treatments is vast and huge. And in the interest of time, I kind of kept it very simple. There are some cancer-associated cancer treatments that are associated with a increased recurrent risk of thrombosis. We're all aware of the estrogen receptor modulators like tamoxifen, progestins, and some of the aromatase inhibitors. Interestingly, there was a paper in Blood recently around tamoxifen, and the risk is highest in the first few months of therapy and seems to plateau out for patients longer term. And the risk is higher for tamoxifen than it is for some of the aromatase inhibitors. Thalidomide analogues in patients who have a haematology background are well recognised, and it's one of the few groups where we do recommend primary and secondary prophylaxis for patients who are going on to any of those thalidomide analogues with anticoagulation. Platinum-based regimes, particularly cisplatin, for some of the solid tumours, and then increasingly we're understanding a bit more about the anti-angiogenic agents and growth factor inhibitors and their role in thrombosis. So there are some, we have some data in patients who are on specific chemotherapy agents where we are expecting those patients to be in a higher risk of recurrent and indeed initial thrombosis. So when we're thinking about whether a patient should continue long-term anticoagulation in the cancer setting and non-cancer setting, not only do we need to look at the risk factors for recurrent thrombosis, but we need to look at what potential risks we're exposing those patients to by treating them long-term with anticoagulation. And obviously the major risk for any anticoagulant is bleeding. So can we look at what harm we might be doing to patients by continuing anticoagulation and say, well, is that harm going to outweigh any potential benefit and potential long-term survival benefit by continuing anticoagulation beyond the 6-month period? And taking one of the biggest studies looking at longer-term use of anticoagulation in low molecular weight heparin in cancer patients is the DeltaCan study. And they were looking at efficacy and safety at 6 months and then 12 months in just over 300 patients enrolled. And it was about half patients reached 6 months and about a third reached 12 months. And of those that died, the predominant cause of death was their malignancy, but 4 was recurrent PE and 2 hemorrhage. And we can see that the rate of major bleeding in the first 6 months is approximately 1.7% per month, and it falls significantly after 6 months. And the total VTE recurrence rate is also highest in the first 6 months, falling after 6 months. And if we try and break that first 6 months down a little bit further, we can see that actually the rate of highest bleeding is in the first month and the rate of highest VTE recurrence is in the first month. So when we're looking at the risk of bleeding longer term in these patients, the rate of bleeding really is tailing off quite significantly after 3 months and certainly after 6 months, down to 0.7% per month, and is pretty much equal in this study to the rate of thrombosis. So it doesn't look like we're doing the patients a huge amount of harm. So ideally, it would be nice to have some kind of randomised study to look at long-term anticoagulation, and Professor Noble and the team tried to look at this with the ALICAT study. But it proved quite difficult to recruit into, and there were patient factors, there were physician factors, there were a lot of physicians who didn't want to stop anticoagulation in their patients, maybe because of the heuristic factors that we heard about earlier on this morning. Difficult to know. But the data is lacking, and it's likely to be very hard to recruit patients into these trials. So I think it's going to be very difficult to move forward significantly with our knowledge base at this stage. So Dr. Cohen talked a little bit about the direct oral anticoagulants and how, if we can at all, extrapolate data from these studies with cancer patients. And I think one of the most important things and messages he was trying to put across, and Professor Noble put across this morning, is that probably in these studies we're not seeing the majority of the patients that you're likely to see in the kind of haematology oncology outpatient setting where the more difficult questions arise. You're likely to be seeing in these studies patients who are lower risk because known malignancy, known aggressive malignancy, short life expectancy were exclusion criteria for these trials. So they're probably low-risk patients. They're patients that they might have known had the cancer at the beginning and who were diagnosed with the cancer during their treatment. So it is quite difficult to extrapolate, but they don't appear to be significantly worse than warfarin, excepting that warfarin is not our standard of care. And again, with regards to bleeding, they appear to have a tendency to better bleeding rates, both major bleeding and non-major bleeding, but again, accepting that this is compared to warfarin, which is currently not our standard of care, and this is earlier in the treatment. So we don't have much data around risk stratification beyond 6 months. We have some data to suggest we're not doing a huge amount of harm by continuing low molecular weight heparin as far as bleeding risk beyond 6 months. We're unlikely to be able to recruit patients into large-scale trials to look at what we should do beyond 6 months because of patient and physician factors that are reluctant to engage with those types of studies and have their own preconceived ideas of what they would like at the end of 6 months and what they will and won't accept with regards to side effects and potential risks. So can we learn anything then from our patients at 6 months? And whether there are patient factors that we can understand better that help us with our decision making beyond 6 months. And some of the data comes from Professor Noble. So we understand that symptomatic cancer-associated thrombosis is a distressing experience. Cancer is a distressing diagnosis. Chemotherapy is very challenging to get through, particularly the very aggressive chemotherapies. The surgery can be very challenging and unpleasant. Following surgery, they can be left with complications. They're tired, they're worn out, they've had a horrible journey. They've then had thrombosis. They've then had to inject themselves for a minimum of 6 months. Potentially had bleeding complications, and I think there's no underestimating the psychological toll that this takes on patients, and they are at their wits' end by the end of it. And even in units where there's a lot of psychological support, it's quite a difficult journey to get through. And patients don't want any more. They've had enough. They don't want any more complications. They want to try and keep themselves as well as possible. I think we are limited on what we give patients with information regarding the risks of cancer-associated thrombosis during chemotherapy. I think we're getting better at it in hospital, but I think we're not very good at it in the ambulatory setting. We're understanding more that actually, particularly from what Professor Noble said, low molecular weight heparins, actually, the injections are often acceptable in the context of the illness and what they've been through. And it's a very different group from a patient who's come in for a hip replacement, gets a deep vein thrombosis, goes home, is otherwise well, their hip is fixed, they're out doing the walks they want to do. It's a very different setting than patients who've got ongoing issues and recovery from their treatment. And compared to what they've been through, perhaps low molecular injections aren't as bad as we think they are for patients in the longer term. And patients often develop habits and rituals to normalise daily injections and make them part of their life and understand the kind of quirks and idiosyncrasies themselves that minimise the bruising that they get or the lumps under the skin or the pain and stinging that they might get from the heparin. And an ideal anticoagulant for patients in order of preference, as we've heard earlier, is often the least interference with their cancer treatment. It mightn't be what we think it is. We might think, crikey, why would you want to stab yourself every day? But actually, if it's the drug that's going to interfere least and that they know about the most, they understand that we know about the most, is probably most important for them. The lowest thrombosis recurrence rate comes in pretty close behind it, and minimal bleeding risks. And then oral, once a day, no need for monitoring, actually comes a bit further down the line. And again, these patients are often up for their review clinics anyway for clinics, so monitoring isn't such a big deal for these patients. So what can we say at the end? Well, there is limited evidence on which to make decisions. And it's going to be that we have to look at smaller papers and fewer randomised, big kind of grade A randomised controlled trials to be able to talk to patients about the data for their thrombosis. And prior thrombosis, severity and recurrence on anticoagulation are quite important. The thrombogenicity of the cancer, again, and within that cancer, it will change over a period of time, and you may well have a patient with a very aggressive diffuse large B-cell lymphoma at the beginning with recurrent thrombosis on anticoagulation, but by the time they've had their R-CHOP chemotherapy and everything's settled down, their thrombosis risk is very different than it is from right at the beginning because of all these different factors that feed into cancer-associated thrombosis. The thrombogenicity of the treatments, chemotherapy, immunotherapy, hormone treatments, combinations of those drugs together. The bleeding risk, tumour type, concurrent illness, how unwell are they? And I've put patient views in bold at the end because beyond 6 months you've treated their thrombosis is secondary prevention, and their patient views play a bigger role in this because there is less data and less grade 1 and grade A evidence for all the other things that we've talked about above. And you saw this slide earlier from Simon Noble, and I think it's a nice summary slide to end on when you're talking about whether we should extend anticoagulation in cancer-associated thrombosis. Patient preferences at the top. And the factors that would favour continuing anticoagulation is the higher risk of recurrence. But that would be balanced again if they have an ongoing bleeding risk, they've got persistent thrombocytopenia, they've got problems with hemorrhoids that keep bleeding that's affecting their quality of life, you might well stop anticoagulation. Malignancy specific follows behind active malignancy, the higher risk malignancies, metastatic disease, ongoing chemotherapy in that setting. And then the other factors, bit less so, previous history of VTE, the nature of the initial VTE, and then risk of hemorrhage. But I think the key message with these patients is that there isn't grade A evidence, and patient preference and probably your heuristic experience, heuristic memories are going to play a greater role. So what did we do with patient AB? So he was the patient with the esophageal carcinoma, the local node involvement, who'd had the cancer, the incidental PE early on. The patient did continue with actually prophylactic dalteparin. The rationale being that we didn't want to give him bleeding complications, that actually after 6 months in patients without cancer, thromboprophylactic doses are adequate to prevent thrombosis. And once he'd completed his chemotherapy and he'd confirmed his cancer was in remission, the prophylactic dalteparin was stopped, and he had no further thrombosis recurrence and was very pleased. And patient BC, the 45-year-old lady with breast carcinoma and nodal involvement, was very unkeen to have another thrombosis. She found it a very distressing experience. She didn't want persistent worsening leg swelling over a period of time for recurrent thrombosis, and she felt that the risk from the tamoxifen, when we talked about the percentage thrombosis rates, outweighed the risks from continuing anticoagulation, and she wanted a direct oral anticoagulant. So we elected to put her on Rivaroxaban 20 milligrams as secondary prevention until the tamoxifen was complete, and at 18 months down the line has had no thrombosis and no bleeding complications either. And psychologically, I think that's been a significant benefit from her, given how difficult she found things. So thank you very much for listening to a talk where there is limited evidence. And I look forward to the kind of panel discussion on questions and thoughts from the audience, because I think it's a team effort managing these patients, and I think multidisciplinary approaches from doctors, nurses, pharmacists, oncologists, haematologists, cardiologists is the way forward as we try and learn how to minimise the complications of these patients who have an already very difficult time in their patient journey. Thank you very much.